Hi everyone, this is part one of the Hematologic and Immunologic lecture. The first thing I'd like to do is review some of the blood components, just for a refresher. We have our RBCs, or our erythrocytes. They carry oxygen. We have our WBCs, or our leukocytes, which help fight infection. We also have our platelets, or thrombocytes, which help stop bleeding. Another thing I want to talk about here is a left shift. Just as a refresher, don't forget that a left shift is when more band cells, and the band cells are those immature white cells, when we have more of those in the CBC with differential. When we see the band cells, we know that the body is attempting to fight a very active infection. Normal amount of band cells is 2 to 6% of the WBC. If it's increased, the body is just kicking out these immature white cells to join the rest of the white cells in the fight of infection. And again, they're immature, so they're not doing their job. They won't be helpful, okay? Next, you'll see a chart here, and this chart really is just for a reference. We see the RBCs, the hemoglobin, the hematocrit, the WBCs, and the platelets. And we see how those things differ in a newborn to through the different ages. We got 1 year, 5 year, and then 8 to 12. Okay, so those are normal values for those ranges. And the next slide, I'm not going to flip to it so we can look at the chart, but it does say, why is a newborn so high? Don't forget that the embryo has additional sites of blood cell formation, such as the spleen, the liver, the thymus, and the yolk sac. At birth, blood cell production occurs in almost every bone to promote growth. And in adolescence, we see only flat bones that are creating these blood cells. Some examples of a flat bone: sternum, ribs. All right, let's talk about some of our red blood cell disorders. And don't forget, you guys, I did email you this handout so you can take notes on it as well. The first thing I want to review is anemia. I know I talk about anemia a lot, but it is obviously an important concept to a lot of our disease processes. It says number of RBCs below normal. Why? So think about why we could lose our RBCs. It could be because of a trauma. We have excessive blood loss due to that. It could be because somehow our red blood cells are being destroyed. Think about sickle cell and or AIDS, what it does to our RBCs. And it could also be because we have a decrease or impairment in the production of RBCs. Is it our bone marrow failing? Do we have an iron deficiency going on? So again, you just kind of look at the clinical picture. Why are RBCs below normal? You need to figure out the cause and treat it. We'll talk about some of those causes as we go on. Some clinical signs of anemia, just to reiterate: muscle weakness, fatigue easily, pale skin color, pica, dizziness, lightheadedness, exercise intolerance, headache, irritable, impaired cognitive skills, just to name a few. Our first RBC disorder that we'll talk about is iron deficiency anemia. I talk about this one because it is the most common type in children. Causes could be blood loss, increased demand, so rapid growth in childhood. When I think of rapid growth, I think of our adolescents when they're having their growth spurts. So they're growing so fast that their body has these increased demands and the body can't meet those demands, which results in iron deficiency. It could be poor nutritional intake. There is such a thing as a milk baby. And also it could be the reduced fetal iron supply because the baby was born prematurely. Kind of don't forget to what's going on in the body here. The heart is beating a lot faster to compensate. We have to get, the body has to get out what little O2 it has, what little oxygenated blood it has out into the peripheral. Okay, so the heart's beating faster to make that happen. And again, let's talk about a few of the labs you would take a look at. Obviously, we would look at our hemoglobin, our hematocrit, our red blood cells, and then we'd want to look at our serum iron concentration to see what's going on there. Our goals with iron deficiency anemia, we've got a couple of them. We want to increase oxygen supply to the body tissues and promote adequate rest. And again, so I think about our breathing here. And again, what position is best to help get that oxygen supply to body tissues? What position is optimal for chest expansion and breathing? Semi-fowlers. We could give them oxygen as needed. We would, to promote adequate rest, we would obviously want to provide for periods of rest. We'd want to cluster our care. We would also want to assist with their ADLs. Another goal is to increase intake of iron-rich foods to meet minimum daily requirements and also to increase those iron stores. So let's talk a little bit about that treatment. How are we going to treat this? Again, it will depend on the cause. You know, we talked about, is it because of a blood loss due to a trauma? That very well could result in a blood transfusion. Is it because their growth demands nutritional intake? Okay, so we really just want to look at the cause. If we're looking at iron deficiency anemia related to inadequate iron in the diet, and that typically is our #1 cause, we want to do some dietary counseling. We want to make sure that the child is put on iron supplements. There's drops, and we want to make sure, remember I talked about a milk baby? We want to make sure that for that first year of life, breast milk and or formula is what's best. We want to see, we could offer vitamin C because that facilitates absorption of iron. You can also do IM or IV iron if the oral doesn't work. I've typically just seen iron replaced via IV. I've never given iron IM in my practice. We talk about the diet and the older child becoming a milk baby. We want to, as they get older, we want to offer milk or formula after solid foods that are rich in iron have been eaten. We don't want them to fill up on their formula or milk as they get older when we start to introduce solids, okay? So dietary supplementation would be one treatment, and counseling. Make sure we're giving vitamin C. The other treatment would be packed RBCs. Again, that's only used in severe anemia. Serious infection, if we see cardiac dysfunction because of this iron deficiency anemia. And then if it's a surgical emergency with anesthesia is when we'd give packed RBCs. Some of our nursing care, education, again, causes. We need to do some dietary counseling. What is, you know, have we introduced milk too early? Have they not been supplementing with iron fortified cereal at the right time? We want to make sure that we are doing some dietary counseling when the child is eating table food, the foods that are rich in iron. Unfortunately, the foods that are rich in iron aren't necessarily appealing to younger children. It's green leafy vegetables, it's liver, red meat has iron in it, so we need to look at those things as well. If we're doing supplementation, if it's the oral drops, we need to make sure that they're taking it through a straw because it will stain the teeth. We need to make sure that they're aware of the side effects. Black stools could be greenish in color. Iron is very constipating, so we want to make sure that we're doing adequate hydration, if not a little bit more than adequate, to minimize those side effects. And the iron, if they're taking it orally, it does have a foul aftertaste. It's important that we do address this issue because if left untreated, it will slow the child's growth and it will affect their cognitive development as well. When we come back to campus, part of our review session for this content, I do have some case studies that we will go over in class to reiterate the information that I have presented here. Sorry, you guys, I kind of keep forgetting to click my slides. All right, the next content will be sickle cell anemia.